Good afternoon, everyone, and welcome to the first of our webinar series from the Shine a Light group here in Sydney, Australia. I'd like to introduce myself. My name's Gary Morrison, and I'm part of the management team, which runs Shine a Light group. And we are just delighted to be able to bring this webinar to you. Our aim is over the course of the next 12 months to bring a number of webinars with practical issues as they relate to cancer and particularly prostate cancer. Today's webinar is on urination troubles after surgery and radiation therapy. And I'm delighted that we have our guest speaker, Vincent Tse, who's a functional urologist from Sydney here in Australia. Vincent will give a little bit more background on himself when he starts. I'd also like to welcome three of our members from our Shine a Light group, each having had challenges with continence, and we're going to be giving you some background as to their experiences, the challenges they had, and the successful outcomes they've had in relation to continence. My co-host today is Dr. Kelly Spencer, who's also part of our management group, and Kelly is going to be co-host. He'll be driving most of this webinar, and then I'll be coming back in during our question and answer component. I'd particularly, just before I pass over to Kelly, like to welcome participants in the webinar from all around Australia, New Zealand, and also Singapore. So welcome to you all. I hope you find it an informative session. That's our aim, a practical informative session. So right through Vincent's presentation, you'll be able to ask questions. We'll be monitoring that, and we'll endeavour in the 2-hour period to be able to answer your queries and certainly give you some fruitful information. So on that note, I'll pass over to Kelly and get the webinar started. Thank you.
Thank you, Gary. And I think it's fitting just to do an acknowledgement of country before we begin. So I'd just like to begin by acknowledging the traditional custodians of the land on which we gather today. I'm coming to you from the Gadigal land here in Sydney, and I'd like to pay my respects to their elders past and present. And I extend that respect to Aboriginal and Torres Strait Islander people if they're here in our meeting today. So thanks for the lovely introduction, Gary. And if anyone wants to post where they're coming from, which land they're coming from, they can do that in the chat function. This is an interactive session, so we encourage everyone to please use the Q&A button at the bottom. Or the chat function you'll see at the bottom of your screen. Please post your questions there, and either we'll pose them to our speaker while he's presenting, or we'll do it at the end. Once he's done with his talk, we will then open up to our panel, and our support group members who have, as Gary said, had lived experiences will tell us a little bit about their story, and you'll have an opportunity to ask them a little bit about their experience. And also to speak to Vincent and ask him about any questions that you have related to urination troubles, either before surgery or even radiation, or even if you haven't had any of those, anything related to urination troubles. That's the topic for today. So what is a functional urologist? They are urologists that have studied, like all other urologists, done general urologists, and then they have a special interest in issues related to urination, the bladder, the urethra. So normally they go overseas and they do a specialized fellowship, and that gives them the ability to manage all issues related to things like incontinence. So Vincent Tse, we're proud to have him as our guest speaker today. He works at Macquarie University Hospital, as well as the Concord Repatriation Hospital here in Sydney. He manages, as I said, issues related to male and female incontinence, bladder, prostate, and pelvic floor problems. He is very well renowned nationally, but even internationally. He's written many book chapters, many journal articles, and often is invited to national and international conferences. He's also been the president of the Continence Foundation of Australia. He also is in the functional urology section of the Urology Society of Australia and New Zealand, the Urology Society, yeah, and also the past president of the Pan-Pacific Continence Society as well. Currently, he's a very busy man as he is organizing the International Continence Society meeting, that's ICS, which was due to be held in Melbourne had we not had a global pandemic. We would have had everyone from all over the world coming to hear what he and his team had put together. But instead, they're doing that virtually, and that will be taking place in the next 2 weeks. So we're so incredibly fortunate to have someone of Vincent's caliber address us today, and please use this opportunity to ask whatever questions you have. And I'm now going to hand over to Vincent. Thank you, Vincent.
Thank you very much, Carly, for the very, very kind and generous introduction. And thank you to all of you here listening and watching, and thank you for devoting your time to discuss this quite important issue of urinary and bladder issues after prostate cancer treatment, which includes radical prostatectomy, of course, and also radiation therapy. And I think it is a topic that is, you know, incontinence is always a bit tabooed topic, and it is something that can be very embarrassing, and a lot of patients hide it in themselves. And of course, if you have a very, very loving close family, you may share that with your loved ones, but it's often, you know, quite embarrassing, and you don't want to talk about these issues to sometimes even your relatives or best friends. So a lot of people sort of suffer in silence, and we needn't have to do that anymore. You know, this is the 21st century, 2021, and there are plenty of treatment options available to patients with urinary incontinence after prostate cancer treatment. So over the next 40 minutes or so, I'm going to share with you some insights into what is the problem, the scale of the problem, some of the you know, if you have bothersome enough incontinence and you want treatment, what are the steps that are involved in getting that treatment? What are the actual treatment options, and also what are the outcomes? So there'll be plenty of time for you to ask questions. Now, so having set the scene for you, the International Continence Society, ICS, which is the peak international body in the study and management of incontinence, both urinary and fecal incontinence. We're having our 51st annual meeting starting in 2 weeks' time, as Carly just mentioned. Last year's meeting was also on a virtual platform. It would have been in Las Vegas, USA, but we couldn't make it. What a shame. But hopefully next year, in August, it'll be in Vienna, Austria. So hopefully in August next year, we will be able to go to Europe for the meeting. But we were very lucky to have the meeting here in Australia. Now, so the ICS defines incontinence as the objective demonstration of involuntary loss of urine subsequent to bladder and or sphincteric dysfunction. Now, to set the scene for you, as urologists, as functional urologists, actually, we're actually plumbers. We have to fix leaky taps. It sounds easy, but actually it is a very, very complex problem, because the anatomy and the nerve supply and how the bladder and the urethra and the sphincter works actually is quite complex. It's all sort of governed by the brain and the spinal cord.
Vincent, sorry to interrupt. Can you share your screen, please? Thank you.
Oh, sorry, I forgot to share my screen. Hang on 1 second. Can you see it now?
Yes, we can.
Oh, good. Okay. Yeah. So that is when I was talking about us being plumbers. This is what we have got to fix. It looks simple, but it's not simple, and we'll go through it very shortly. Now, there are different types of urinary incontinence, but a simplistic way of looking at incontinence is either stress incontinence, which is a bit of a confusing term to lay people, because when they see stress incontinence, they thought, you know, is it from psychological stress? But it is not psychological stress. It is physical stress. It is raised abdominal pressure. So a better term is probably activity-related incontinence is a better term rather than stress incontinence. So that is from coughing, sneezing, lifting up your grandchildren, going to the gym, swinging a golf club, climbing a mountain, things like that when you leak. So that's with physical activity. The other type is urgency incontinence, and that's very different to the first one. That is when you leak because you cannot make it in time to the toilet. So that's urgency. There's a time factor involved. And sometimes patients may have a mixed stress and urge incontinence together, but usually one predominates over the other. You know, usually once, you know, it's very rarely 50-50. Now, so how does urinary function actually works? Now, the bladder does two things. It stores and it empties. So the bladder collects urine from the kidney, and then it stores. And it usually stores at a very low pressure. It's a bit like when you're trying to blow a balloon. You know, you blow air into a balloon and the balloon distends very easily under very low pressure. And I'll go back to this in a few moments. This bladder relaxation and storage under low pressure is a very important concept to understand. And then the bladder empties. Now the bladder, well, when the bladder actually stores urine, when the bladder is storing urine, just like now when you're listening to me, your bladder is storing urine. And the sphincters, you can see there are the external urinary sphincter just below the prostate here. I hope you can see my arrow, but if you can't, the pelvic floor muscles and the external urinary sphincter is just below the prostate here. It acts like it's like a cylinder of muscle that wraps around just below the prostate, and it closes the urethra, so you can store urine while you're listening to me without leaking. There's also another sphincter which is higher up. It's at the bladder base, it's at the bottom of the bladder, where the bladder funnels into the urethra. That's called the bladder neck sphincter. Bladder neck sphincter. And when you do a radical prostatectomy, a lot of surgeons now try to reduce the operating and dissecting around the bladder neck. It's called bladder neck preservation. And bladder neck preservation has been shown in some studies to return your continence earlier. It doesn't actually prevent you from getting incontinent, but if you do bladder neck preservation, there is some data to show your continence may return earlier than if you don't do bladder neck preservation. But whether that can be done or not depends on the location of your cancer, of course. If your MRI or your biopsies show that your cancer was very close to the top of the prostate, very close to the bladder, then maybe your surgeon cannot do bladder neck preservation because you've got to clear the cancer. So that's so that has to be discussed with the surgeon. Will discuss that with you. You know. So that's how we become continent when the bladder stores urine. Is the bladder relaxes to store urine and the sphincter becomes tightened so that urine doesn't leak. And when you need to urinate, your bladder contracts. You know, the bladder is like a muscular sac, it contracts, and then the sphincters open. Both the bladder neck and the external sphincter lower down will open, and you can void. Now, so why would somebody become incontinent? Well, you could become incontinent nowadays due to doctor-induced, and it's usually due to, in men, prostate surgery, either radical prostatectomy for cancer or a TURP, which is like a prostate rebore, which are done for benign prostatic enlargement. When you have blockage to your flow due to benign causes, you have prostate transurethral prostatectomy. Nowadays we have other more novel treatments like Urolist, which are two staples that distracts the prostate open. To distract the prostatic lobes so that the urethra opens more. So there, these are the more newer treatments. Now you can also have incontinence if the pump doesn't work properly. Okay, and that's the bladder. The bladder, as I said, is a muscular pump. So if your pump becomes what we call overactive, sometimes with aging, the bladder wall becomes overactive. It just twitches all the time, especially when it's full. And then you get all of a sudden an urge to have to rush to the toilet. And if the toilet is not right next to you, you may leak. And so that's overactive bladder. Now, reduced bladder compliance is, we go back to that balloon analogy I talked about. The bladder should, it should be like a balloon. It blows up very easily under low pressure. But if you have a balloon that is like double thickness or triple thickness, then it becomes very stiff. And to blow air into that thick balloon, you have to blow it with a lot of force. So there's a lot of pressure built up inside that 3-layer balloon versus the single-layer balloon, given the same size of the balloon. Okay, so that's called reduced bladder compliance, when the bladder is much stiffer. And of course, other pelvic surgery or pelvic trauma can cause incontinence, because if the nerves are damaged, if the nerves of the bladder are damaged or the nerve to the sphincters are damaged, you can get incontinent too. And there are other rarer spinal or neurological disease such as stroke or multiple sclerosis or spina bifida can also give you incontinence. Now, you are actually not like, if you do have incontinence, those of you who are in the audience there, it is a very big problem. In 2010, the Continence Foundation of Australia actually commissioned Deloitte, the auditing company, to look at the financial cost of incontinence in Australia in that year. I think it was 2010 or 2011. And you will not believe this. The total cost, both tangible and intangible cost, is over 2 billion Australian dollars. And most of that is due to urinary incontinence, and a minor component is from fecal incontinence. But can you imagine, $2 million is the cost of incontinence in 1 year? It is more than hemodialysis in renal failure. Now, so why is incontinence important to talk about? It is not the world's most glamorous topic, but it is the one that erodes most into the quality of life. Some of you in the audience here might have had a prostatectomy detected by raised PSA and then biopsy, and then, but you don't suffer from that. You don't suffer from a raised PSA. You don't suffer from an MRI, but you will suffer from incontinence. But it is often, even specialists, they just mention it on passing. But they really need to spend a bit more time during consultation, before surgery or radiotherapy, to talk a little bit more about the incontinence. When I do radical prostatectomy too, and I tell my patients, you may have incontinence, and if it happens, it's not the end of the world. We can do this, we can do this, we can do this. And if you have erectile dysfunction, it's not the end of the world either. We can do this, we can do this, we can do this. So at the end of the consultation, they feel a bit better. It's still not nice, but they at least feel better that they know that they don't even have to have incontinence. They don't have to live in pads forever. And having that knowledge before they actually have the surgery or the radiotherapy is very important. And I'm sure a lot of our colleagues now have do that, and also they have nurses or other allied health professionals in their practice who can counsel these patients before their prostate cancer treatment. The other very big thing is also physiotherapy, pelvic floor physiotherapy, and I'll talk about that in a second. And that's because of all these things you can see here. You know, there's embarrassment. Some people even get into depression because of incontinence, and it's something that we do not have to suffer nowadays. And about 150 men, you know, in some of these studies reported practical inconvenience. You know, there's extra laundry. They fear that they smell. There's extra cost of getting pads. The excoriation of the skin from the acidity of the urine. Some of these really bothersome symptoms. And this is from a study from a while ago, but it is one of these landmark studies. So I think if you do have urinary incontinence in 2021, it is unacceptable and we need to fix it. And I can probably say from my 19 years of experience dealing with these problems, almost every single one can be fixed secondary to prostate cancer treatment. Some could be more difficult than others, but generally speaking, at the end of the day, you don't have to be wet.
Vincent, there's a question that's come in, and maybe you're still going to address it. Is there a difference in incidence of incontinence between open surgery and robotic prostate surgery?
Yes, there are multiple high-level trials and papers that have been published establishing the superior continence from robotic prostatectomy versus open, and it's a bit of a no-brainer for doctors, mainly because the robotic you have magnification, 2 or 3 times magnification, so the nerve sparing part of the surgery is a lot more accurate than if you just eyeball it, standing next to the patient, looking down into the pelvis 3 feet away. So the nerve sparing, and many of my colleagues who have done both open and robotic surgery in the last 20 to 30 years, they all mention the same benefit, is they notice that their patient's continence rate is higher than when they used to do open surgery. And once you've done robotic surgery using the magnification, you will understand, you would say to yourself, what we used to do with open is really quite primitive, you know, if that's a word for it. It is just no comparison. The detail of the anatomy you can get with robotic surgery. So I hope that answered that question. Yes, so Carly, feel free to interrupt me if you need to make comments. Now,
I will, Vincent. Yeah, I'm monitoring the chat.
Yeah, good.
So
yeah,
I'll do that. Thank you.
And yeah, so and let me know too when it's 10 minutes to about 2 o'clock. Yeah. Now, so when you have urinary incontinence, what actually happens when you go and see the GP? So of course you see a GP first, and usually once GP sort of sorted out, you know, go through some basic investigations and make sure it is not, you know, due to a urinary infection or other GP related bladder problem. They usually will refer you back to your urologist, and some patients would directly tell their urologist this problem. I know some colleagues after about 12 months, if the patient's PSA is stable after prostatectomy, the urologist refer the patient back to the GP for regular follow-up. So some patients may not have seen their original urologist for quite a while. So when there's incontinence, then you probably should reapproach that urologist and let him or her know that you have an incontinence problem, and they were trying to work you up. So this is what we do. We take a good history. We do a focused physical examination, make sure that there's nothing neurological that's happened to you, which could then explain the incontinence. Usually the neuro exam is normal. We check your urine, make sure that's not a urinary tract infection. We'll do a bladder ultrasound to make sure that you're avoiding reasonably well and not leaving too much residual urine behind. And sometimes to work you up, we have to perform a study called a urodynamics study. It's a computer test of lower urinary tract function. So it's a check of your bladder function and your sphincter function. And we only do that because it's slightly invasive. We have to put a catheter in your bladder and a little balloon in your rectum just for about 20 minutes to do the test. So it's slightly invasive, but we only do that if you think about having surgery done to treat the incontinence. Sometimes we have to do a cystoscopy, which is a look in the bladder and the urethra. If you have if we think you have a stricture, which means a narrowing of the urethra, usually at the joint where the bladder neck joins onto the urethra, sometimes you get a bit of scarring there and narrowing there. We call that a stricture or a stenosis. And sometimes these scarring and narrowings can also occur after radiotherapy, because sometimes even though we have very good radiotherapy now, you can't help but having a little bit of the radiotherapy seeps to some neighboring tissue, such as the upper urethra, and then the upper urethra can sort of scar down as well. So sometimes we have to do an inspection with a camera, which is a cystoscopy, to have a look. Usually we start with the urodynamics first if you want to have something done about your incontinence, and if the nurse can't put the catheter in during the urodynamics, then we suspect a stricture. Then you proceed to have a cystoscopy first and have that stricture treated, and then go back to the urodynamic at a later date to complete the urodynamic, because you can't do the urodynamics unless you can put a catheter in. Now, so if you have urinary incontinence, then there are different types of management options, and these are very broad categories, which are simple, pads. There are some medications, and there are the surgical procedures. Now, before I go on to these, let me just preempt by saying, because some patients may ask me, I'm incontinent after my prostatectomy, when should I get treatment? Generally speaking, if your incontinence has been shown after investigations to be stress incontinence, which is activity incontinence, then no medication would be able to treat that, because it's a weakened sphincter. It's a loose washer in a tap, so no tablet will fix that. You have to have an operation to increase the compression of the urethra. If your bladder is overactive, if the urodynamic computer test picked up that your bladder is overactive, which is what I talked about before, then there are medications for that to calm down the spasms, so your bladder can actually store much more easily under low pressures. Okay, so if it's overactive bladder or poor compliance, the stiff bladder, then usually medications. But if it's just all activity related, then you need to have an operation to increase the compression of the urethra. Normally, when it's stress urinary incontinence, you should wait at least 6 months out from your radical prostatectomy, because during the first 6 months, your nerves in the pelvis do undergo some recovery. The first 6 months would be the most likely period, but that's not to say at the end of the 6 months, your nerve stops recovering. In fact, nerves continue to recover because, every nerve is different, just like, everybody in this world is a bit different. We're all individuals. So all the individual nerves down the pelvis, some of them may take 12 months, some of them may take 18 months to recover. So we generally don't recommend any surgery to fix the incontinence until at least 6 months has elapsed from your prostatectomy, usually more likely towards the 12-month mark. Yeah, because with physiotherapy, pelvic floor muscle exercises, patients still have a chance to improve spontaneously before the 12 months. Now, so let's go into treatment. As I said, they're conservative and operative. So conservative management, there are a lot of pads in the market. If you go to any chemist shop, there are myriads of pads ranging from different prices, ranging from thin to thick, number 1, number 2, number 3. Some of them are pull up like short like pants for the people who really unfortunate enough to get a lot of have a lot of incontinence. So they come in different shapes and sizes. The nurses in the hospitals, the urology nurses are really, really good, and they know the features of different types of pads. So you could tap into your urologist nurse knowledge for conservative management, like which pads are the best for you. Now, with medication, as I mentioned, for stress urinary incontinence, activity-related incontinence, there's no medication presently available in this country. There is a drug called duloxetine, which is an antidepressant, but its side effect is urinary retention. So, but unfortunately in Australia, this drug is not registered for urinary incontinence. It is only registered for depression. But in England, for example, it is registered for stress urinary incontinence, especially in female stress urinary incontinence. So in the UK, if a lady have incontinence from coughing or sneezing, she can be given duloxetine to treat that. It is not really that impressive, the results, but if you have only very mild stress urinary incontinence, the duloxetine may just tighten up your sphincter a little bit, and you leak a little bit less. But in Australia, it is not approved for stress urinary incontinence. Do not ask me why. It is just the way it is. Now, these devices, these are the really sort of primitive, the old ones. There are some newer ones that are in that little black box on the upper end part of the slide. They're called a dribble stop clamp. That's one of the trade names of one of them. There are about 2 or 3 of them in the market, but the one that I've been using for a long time is the dribble stop clamp. And they're quite nice because they're very light, they're plastic, and they've got a firm sponge in the middle. It's just like a peg. And you can wear that when you have to go out to see friends or go for a social event without having to be too embarrassed. I also use it when patients are on the waiting list for anti-incontinence surgery, or in patients who do not want to have surgery. They just wanted to use something like this, and they're happy with it already. So they are there for you to use, and most people tolerate it quite well. Some people find it a bit painful, but you shouldn't use it for many consecutive hours. You definitely shouldn't use it 24 hours a day. Maybe only several hours, or to a level that you can tolerate. And there are different grip strength. Sorry.
No, sorry. I just want to ask, do you know where people can get them from?
Yes, you can get them from a couple of sites. The Bright Sky. Some of you who in the audience who have incontinence using pads may have heard of Bright Sky. If you Google Bright Sky, they are in Silverwater, the head office. and you just got to ring them and tell them that you have this issue and you want to buy some of these gadgets, and you just got to establish an account, and then you can get it from Bright Sky. They sell all incontinence products, everything that you ever need will be sold by Bright Sky for bladder problems. Yeah. The other one is Seiko. Seiko is actually based in Shepperton in Victoria, and they are another company that responsible for some of these products. So there's seiko.net.au, SAYCO, yeah, SAYCO, seiko.net.au. You can also get these triple stop clamp from Seiko as well. But Bright Sky would probably be the easiest, I would say. There are also, there are also these condom-looking drainage device for maybe more frail older patients, maybe in a nursing home, who has poor manual dexterity, and then usually the nurse or whoever they live with roll up one of these onto their penis and collects the urine, because the end of that can be connected to a catheter bag, a leg bag. So, even a frail elderly patient can still live with dignity and not having to wear pads all the time. I think nowadays, even in nursing home, the only people who should be wearing pads are when you exhaust all of these avenues. Sometimes it upsets me when I see, daughters and sons bringing in their elderly parents who may have some dementia. They come from nursing home, and then they just live with pads all the time. And I said, had any one of you had any health professional told you can get these condom catheters? Just roll up one of these onto their penis and then connect it to a leg bag, and they'll be dry. They can sleep through the night dry. They don't have to get up, sleep with wet pads or have somebody coming to help change their pads all the time. So these are just sort of comforting devices that should be made more aware. And I think the Continence Foundation of Australia is doing a very, very good job every year by promoting the awareness of incontinence problems and making the community aware that these things are available. The lower picture is the urinary catheter. We don't like to leave a catheter into a bladder to treat incontinence unless it is a last resort. Now, what are some other more conservative options? There's behavioral modification. By that, what we mean is if you have an overactive bladder, sometimes you need to change your diet. You might have to reduce caffeine intake, because tea and coffee have caffeine and they stimulate bladder function. So if you have overactive bladder, you need to cut down on caffeinated drinks. If some patients, and in those patients, we also give them medications to try to reduce the bladder spasms. And when they take these medications, they need to do what we call bladder training, which means they need to hold on to their bladder, to try to expand their bladder. Because very often with overactive bladder, people's bladders are a bit smaller because they go all the time to the toilet. So their bladder is never allowed to expand properly. So when they're on these medications to try to re-expand their bladder, we teach them, or the nurses teach them, how to hold on to their bladder for longer before they go. So over a period of time, the bladder will enlarge. And when you have a bigger bladder, bigger capacity, you go less often to the toilet. Yeah.
Oh, sorry, maybe this is an appropriate time to ask this question that's come through. I'm generally able to control reasonably well during the day, but sometimes at night I leak during my sleep. I've tried to identify triggers, but have not been able to identify anything. What can be done for that?
Yeah. So if you can control it better during the day and not so well during the night, you are not the only one that complains about this. It is a very common symptom. Why? Because during the day, your brain is switched on, so that you are, so even though you have overactive bladder, you are still able to control it better during the day. But once you fall asleep or you are tired, because a lot of patients also tell me towards the end of the day when they're tired, their incontinence is also worse. And that's because their pelvic floor muscles and sphincter muscles are also tired because they've been trying their best to hold on to the urine during the daytime. So at the end of the day, they get tired, so they leak more. And also during the night, your brain switches off when you're sleeping, so it doesn't send enough signals to the bladder and to the sphincter to avoid these problems. So a lot of bladder issues are accentuated during the night. Yeah, whether you have overactive bladder or stress incontinence is the same thing. Hope that answered that question. But you need to tell your urologist about this, and you may have to end up having a urodynamic study done on your bladder to ascertain the exact nature of the problem. Yeah, because it could be overactive bladder, or it could be stress urinary incontinence, or it could be reduced, elasticity of your bladder. You know, the double layer balloon versus a single layer balloon problem. All right, so so we've talked about this already, behavioral modification and pelvic floor muscle training. I won't drill too much because I'm not a physiotherapist, but if you get a referral to see a physiotherapist, they have the expertise to talk to you about all there is to know about pelvic floor muscle training. But what I want you to know is that there are ample data out there now for at least 1 month of pre-operative pelvic floor muscle training before radical prostatectomy. There are randomized control trial, high-level data to show a patient should really do at least 28 days of pelvic floor exercises before they have their surgery. And of course, they must continue after they've recovered from the surgery. And I think if you've had a radical prostatectomy or radiotherapy, you should really do pelvic floor exercises as a long-term thing. Just like getting up, brushing your teeth, having a shower every day, it should be a habitual activity so that you strengthen your pelvic floor and sphincter muscles forever. Because as you get older and older, your muscles will get weaker. So, and because you have had prostatectomy, even if you're continent now, it may not necessarily guarantee that in another 10 years time you'll be continent, because if you don't do pelvic floor muscle training. So that's because you have had surgery up there before, and it's disturbed some of the muscle structure and nerve structures. So I think all of you who have had prostate cancer treatment really should see a physio and start doing muscle exercises. Just like going to the gym every day, you need to do your pelvic floor muscle exercises.
Vincent, sorry, going back, I know we're jumping a bit, but I thought we should cover it while we were there. And we are joined by functional urodynamic nurses and prostate cancer nurses in this forum.
Oh,
so,
good. Excellent.
Yes, they wanted to propose the previous question, could it not be overflowing continence with nocturnal enuresis?
Yes, yeah, definitely. So the only thing is with overflowing continence, they are usually also very bad during the day as well. But overflowing continence is certainly a symptom that can present at night as well as during the day. But there are many causes of overflowing incontinence, but the most common cause is what we call underactive bladder. So you have heard of overactive bladder, but there's also underactive bladder, and that is when the bladder muscle has degenerated or is degenerating due to most commonly aging. That's the most common cause of underactive bladder, is aging in the world today. But if you have diabetes, you can also have underactive bladder, because the diabetic poorly controlled may affect nerves to the bladder, and they can get weak bladder too. So yes, so overflow it's more a manifestation of an underactive bladder muscle. Now, so these are what I've got on the screen here is bulking agent. What I mean by bulking agent is like a lip filler, you know, for cosmetic. But you can actually use it. You can actually inject these gels around the bladder neck to close the urethra a little bit to stop. Well, not to stop, but to improve on the leakage. They can't really stop the leakage because they're not that strong, but it is actually not very successful anyway. So it is not really offered at all, or not even first or second line for incontinence after prostate cancer treatment. Now, so let's spend the next 15 minutes or so on the surgery. So there are two types of surgery. Remember the surgery is designed to compress the urethra. The sphincter muscle and the bladder neck muscles have already been weakened after the prostatectomy or radiotherapy, and you'll never be able to get it back to normal. But by putting a sling or an artificial sphincter in, it is sort of like substitute for the one you originally have, and you should still get by with day-to-day life. It's a bit like if a mirror is cracked and you put the pieces back together, you can still recognize your face most of the time, but it's not perfect. So I don't think people should think that these slings and artificial sphincters are going to return them to what they were like when they were 30 years old. It won't be. And if your surgeon tells you they can guarantee you that you'll be dry, do not listen. Go and see somebody else, because you cannot guarantee a patient complete dryness by doing these operations. The aim is to give back some quality of life. And if you're lucky and you didn't have too much incontinence to start with, you may get almost dry. But I think if you are converted to just one small pad or one dry pad per day, you should be very happy already, even if it means that there are a few drips and drabs during the day. Now, so how do we decide when to offer a sling to a patient or an artificial urinary sphincter? If you, I mean, I actually, in my practice, I don't only use number of pads, because pads have different sizes. I actually use pad weight, 24-hour pad weight. So if you look at the left side here, male sling, mild, by that I mean less than 400 grams per 24 hours. So I will tell my patients to weigh all their wet pads for the day, and then subtract the number of dry pads. So if you have to use 4 wet pads during that 24 hours, then it's the weight of those 4 wet pads minus 4 dry pads. Then you get the net urine loss in grams. So if it's less than 400 grams and your bladder contracts properly on urodynamic study, I may offer you a sling. But if your pad weight is more than 400 grams in 24 hours, or if your bladder muscle doesn't contract properly for whatever cause on the urodynamic study, you probably won't get a sling, or won't be recommended a sling, because if you put a sling in somebody with a weakened bladder muscle, you may go into urinary retention, and at the end you'll have to have the sling removed. So underactive bladder is a contraindication for male sling, but it's not a contraindication for artificial urinary sphincter, because with a sphincter, it is a 360-degree wrap. So even if you have a weak bladder, you can still put an artificial sphincter in, because when you open the sphincter with your fingers by squeezing a pump, urine can still come out, you know. But if you have a male sling there with underactive bladder, you may have some form of obstruction, which is not so good. I very rarely do double cuff artificial sphincter nowadays. It's probably a bit overkill.
Vincent, question
Yep.
about the sling. Someone has been advised in patients who have had radiation, the failure rate is very high. Is that true?
Yes, the radiation, if you have a pelvic radiation, a sling is pretty much contraindicated because in the long term, it's not the failure rate is very high. And in fact, our unit at Concord Hospital published on this on the intermediate, like 4-year follow-up. If you have overactive bladder or reduced compliance or radiotherapy, at the end of 4 years after your sling, more than 50% fail. Yeah, so it may work for the first couple of years, but after about 2 years, it starts to fail. And after about 4 years, more than 50 to 60% fails. So nowadays, when we recommend straight up, if you have a radiotherapy, it is probably much better to get an artificial urinary sphincter. If you really want to have a sling put in, then you have to understand that the sling may not work after about 2 years. Yeah.
Vincent?
Yeah.
Sorry, I don't know if you were going to say something else. Another question came in that's asking, is it okay to have an artificial urinary sphincter if you have urethral strictures?
If you have a urethral stricture, that has to be sorted out first. Because you can imagine if you haven't sorted it out first and then you put an artificial sphincter in, then if your stricture recurred and you've already got a cuff around the urethra, it will be very difficult to stabilize or dilate that stricture without putting that cuff at risk, because you have to put fairly wide instruments to the urethra to open up the stricture, and that has a risk of damaging the sphincter cuff. It may cause erosion. I mean, it can be done in experts' hands, but you have to be very, very careful to uncuff, or deactivate the cuff before you put the camera in or the laser fiber or whatever it is. So it has to be done by people who are reasonably experienced with this type of problem. If the sphincter is already in and you've got a stricture recurrence, so it's better to stabilize that first before you put a sling or an artificial sphincter in. And I made it very clear, like that's how I teach my trainees. Is almost never put an AUS in unless you have had your stricture stabilized. There are some exceptional cases, but generally speaking, you should stabilize the stricture first. So this is the advanced sling. There are 2 types of sling in this country. There is the fixed sling, which is the advanced sling. I think we also have the virtual sling. I don't know whether it is still available in Australia. I think it is. The advanced sling is made by Boston Scientific, the old AMS, and the virtual sling is made by Coloplast. The advanced sling is a 2-arm sling, but the virtual sling is a 4-arm sling. But a sling, as you can see here, a lot of patients like slings because you don't have to squeeze a pump to urinate like the artificial urinary sphincter. So as long as you don't leak too much, under 400 grams or so, a sling is quite good. And so here is the advanced sling. We have now got the XP version around the world. The advanced is the traditional version. Now it's the XP, which is a bit longer, and the needles that comes in for the surgeon to use are a bit wider, the radius, because in the US they have they have an obesity epidemic. So the traditional advanced sling needle wasn't big enough for some of those American men. So this is the sling. You can see it's got a rectangle body just under the curve of the urethra there, with 2 arms through the obturator foramen, which is the hole in the pelvic bone. And once we deployed it like this, we then pull the ends of the arms. And when you pull the end of the arms, it lifts up the urethra. That mesh lifts up the urethra and compresses it there. And the art and the skill is how tight to pull it so that the guy will have his continence back, but he can still urinate. I mean, everybody can pull it really hard. You never leak again. You don't have to use any more pads, but you can't pee. So that's no good, right? So you've got to have a right balance that will improve you, but you can still urinate. So in my experience, most patients who have a successful sling operation, they always almost experience a slowness of the flow, but they don't really mind. They just spend an extra 30 seconds to pee because the stream is slower, but then they are happy because their pad usage is much better, and in some cases they don't have to wear any pads. Now, so this is actually, let me talk about, so while we're on sling, so this is the adjustable sling, and in Australia, the ATOMS is the one that's marketed the most. It stands for Adjustable Transobturator Male Sling, ATOMS, and it is made by a company in Austria, I believe. And the top two photos shows the traditional version. So this one is slightly more gadgetry. It works by, the reason why it's adjustable is it works by, there's this cushion here, which is inflatable and deflatable with saline. And this is the port that you can inject saline to inflate the port. So it is placed like this under the bulbar urethra there. And at the conclusion of the surgery, the surgeon put a certain number of mils of saline in there, just enough, but not too much, because the swelling is still there. But after a few weeks, when they go and see the surgeon for follow-up, then the surgeon can top up the cushion. And as you top up the cushion, it gets bigger and it compresses the urethra more. So sometimes you may have to adjust it 1 or 2 or 3 times until the patient says they are reasonably happy. So that's the advantage of the adjustable sling. And this world is very fair. There are always good and bad about everything. So the disadvantage about the advanced XP sling is that it is fixed. So you've got to really, you've only got, the surgeon only got one chance to get the patient better. But the good thing is that once it's put in, you don't have to tamper with any of the gadgetry. But with the ATOMS, the advantage is that you can adjust the volume of this cushion. So if the patient comes back and say, "Oh, look, doctor, I'm still leaking. Can you put a bit more saline in here?" The answer is yes. But the downside is that every time you pierce the skin to put fluid through this port, you have a potential risk of injecting bacteria into this system, even though everybody has to be very careful with sterility when they do the procedure in the office by put the needle through here. But there are cases where germs can be introduced, and then they get an infection. Sometimes the infection is very mild and the patient don't actually feel it, but then from a chronic sort of low-grade infection, these prostheses may erode through the skin, or they may erode through the urethra. So the erosion rate of the ATOMS is much higher than the erosion rate of the advanced sling. So as you can see, there's good and bad for each one, and you've got to sort of take that home, think about it, and then tell the surgeon which one you like. The newer, sorry.
There was a question asking, do you put in the ATOM slings? Do you use them?
I personally don't use ATOM sling because there are a few reasons. Number one is the advanced sling came out to the market first about 10 years ago, and so I learned the advanced sling first, and it took me about 2 to 3 years to get really good at doing them. Like everything else you learn in life, you don't become good straight away. You need to practice, do lots and lots of them, and you learn from your patients, you learn from the urodynamics. So it takes you a while, and then the ATOMS comes along, but then I've already gotten good at doing the advanced. So I said to myself, why should I put myself through the pain of having to learn another procedure if I've just optimized the way I do the advanced. And also at the same time, I also was referred patients who have had complications of the atoms. And then they referred them to me for me to remove. So that's why if you ask me, I've got like a personal bias, because I already got good at doing the advance, and then I begin to see some of the patients who have complication with atoms. So I decided I better don't go there. But having said that, there are many, there are quite a few urologists in the country who only does atoms because they haven't done the advance, and they do get good results with the atoms. So so that's really good, because I think it's good you just do one or the other. It is very difficult if there are so many slings in the market, you're trying to do this one, you never get good at any one of them. So most of us only do one. And if the patient want atoms, I refer them to colleagues who do it. And if the other colleague have patients who doesn't like atoms but want a fixed sling, they refer them to me. So that's how we become collaborative that way.
Vincent, one other question.
Yeah.
This is controversial. Someone is concerned about mesh and the mesh that you use in the sling.
Oh, yes. So I knew that question is going to come up, but let me reassure you, men don't have vaginas. So there's been no issue with mesh. I mean, this has been put in more than 10 years now. The anatomy is very different to the female anatomy. The female anatomy is much more unforgiving because you are placing mesh between the vaginal wall and the urethra or the rectum, which are very thin and very delicate, very soft. Whereas in the male, the urethra, the bulbar urethra, is very thick, and it is extremely rare to get mesh complications. I mean, it is, you still get it, but it is very, very rare, and that's why you haven't heard, even from America, where it is the most litigious, one of the most litigious countries in the world, we haven't heard of any mesh issue, because the anatomy between the man and the woman down there is very different. So it is much more forgiving in men. So, but you just got to be careful in radiotherapy. That's all. In patients who have had radiotherapy, when I don't put slings in anymore because our own data does not support it. So we stopped doing slings in radiotherapy. But with artificial sphincter, you still got to be careful when you do the surgery, and then follow the patients up very closely. But overall, they still get very good quality of life. But radiotherapy patients do have a high erosion rate than non-radiotherapy patients. So as long as they understand it, and when they do have a complication, they come back and see us, and we can fix it. I think it is a very complex issue, that the vaginal mesh, because it is not just the mesh, it is multifactorial. It is a bit like if a plane drops from the sky and have a big accident and kill 300 people, you still fly. You don't stop flying, because you still need to get from A to B, and women still need to get better from their prolapse or their incontinence, so you don't just stop flying. You have to investigate and do more research to find out, are there better materials, or can the technique of the implantation of the mesh be better than the original, method. So there are all these things that we are now trying to, a lot of scientists and gynaes and urologists trying to figure out a way to improve these techniques, so that the women can still benefit and have good treatments. Yeah, but we're using more native tissue now in women, but there are research going on for better tissue engineering for women. But for men, there's no issue. Men, there are just the usual complication. I mean, every operation has complication. So it's just the normal, in quotation mark, normal range of complication for mesh, male mesh slings. Yeah. Yeah, so I think if you have any of these problems, urinary incontinence, whether it's overactive bladder or activity related, you don't really have to suffer in silence anymore. I also feel sometimes a bit upset when I see a patient referred to me, and when I ask them, when was your prostatectomy? And they said 8 years ago. I sort of was thinking, why did it take you so long to come and see a urologist? And I mean, of course, I didn't ask them, but I was thinking, it took them. But I think everybody's different. They go through different phases of their lives. So every individual is different. But some people, I think they left it too long. I mean, we can still fix them, but they left it for so long. They suffer for so long. Why? In this day and age, you shouldn't anymore. Yeah. So I encourage all of you to, if you do have a urinary problem, speak to your GP, speak to your urologist, speak to your allied health professional, nurse consultant, physiotherapist, even other patients in your support group here who have had who have had slings or artificial cuffs put in. Learn from their experience, and maybe you benefit as well. Because thank you very much.
Now, Vincent, are you going to talk more about the sphincter? We have a few questions about artificial urinary sphincter here, particularly related to so one of them is, can the sphincter be?
Yeah, I'm happy to ask. I'm happy to answer any questions now.
Okay, so artificial sphincter, is it compatible?
Oh, sorry. That's because I fast forwarded one slide. Sorry. Yeah.
Yes.
So I go back. Sorry. I got a bit carried away because I'm so passionate about this subject. So yeah, so I go back one slide. So this is artificial urinary sphincter, as you can see here. It is a 3-piece device. It works a bit like a blood pressure cuff, actually. If you imagine, the old blood pressure cuff, this is like a miniature one. It goes around the urethra there, and it's connected to via tube to a little pump about the size of, just a bit bigger than the size of a dice, a dice that's put under the skin of the scrotum next to the testicle. And the pump also has another tube that goes to a little reservoir about the size of a ping pong ball, and that sits next to your bladder. So all of this is under your skin, so you can't see it when you're naked. So what happens is, this whole system is filled with fluid under pressure, right? So this whole system is filled with fluid under pressure. So the pressure in the cuff would compress the urethra. It's a 360-degree wrap around the urethra. That is why the artificial sphincter is the gold standard in management of urinary incontinence. Whether you use 1 pad a day or 10 pads a day, the artificial sphincter will fix it. But if you use 10 pads, a day, the sling won't fix it. Okay, because a sling is only providing half a circle, or just like a hammock sort of thing, whereas this is a 360. And when you need to urinate, you squeeze the pump, you squeeze the little pump here. And when you squeeze the pump, you suck fluid away from the cuff into the balloon. Okay, so then the urethra opens up and you can urinate. And about 3 or 4 minutes later, the balloon will automatically, by passive recoil, push back the fluid back into the cuff. So that takes about 3 or 4 minutes, and then you'll be continent again. And then the cycle starts again when you need to urinate. You squeeze the pump again, and then the cuff deflates and the urine comes out. So it is a pretty genius device, because all you have to do is, when you need to urinate, you just squeeze the pump, and then the rest is automatic. You don't have to close it. You just got to open it, and it'll close by itself after a few minutes. So it is and it works like clockwork. It's a bit like mechanism in a watch. It's very consistent, and it lasts, generally speaking, about 5 to 7 years. So that's a very ballpark figure. So about every 5 or so years, one of these parts may undergo materials fatigue. There may be little hairline cracks appearing in the material, and you may leak a bit of fluid. So once you lose a bit of fluid, then the pressure is lost in the system, and the cuff doesn't compress properly because of a fluid leak. And then you've got to have the thing change, the gadget replaced, and replacing it is easier than putting it in. So so you don't have to be too fearful about getting it replaced several years later. I mean, I've had patients who have had this last more than 10 years, more than 12 years in their body before they change. But on the other side of the coin, there are also people who only last 2 or 3 years and you have to change it. I'm not sure why some of them last so long and why some of them doesn't last as long. But as I said, every individual is different, and the material reacts differently inside the body of different individuals. So that's the way it is. And also it depends on their urodynamics findings. Some people might have more favorable urodynamic parameters, so that they maintain continence a lot longer with their device. But if you've got urodynamic features, for example, overactive bladder or some other issue, then you may begin to leak a lot earlier than another person with the same device. Yeah, but overall, it's a very simple procedure to do. It takes less than an hour to do, less than an hour of general anesthetic. And then we switch it on 6 weeks later. So when you go home, you still got to go home in your pads, use pads or use your triple stop clamp. And then when you come back in 6 weeks, when all the swelling, bruising, and so on settle down, then we activate the device by pressing the pump in a certain sequence. It's very simple to do. And then I will make sure that the patient can operate the pump properly before I let them leave my office. So when they go home, they can always urinate. I've never had a patient who cannot urinate when they go home, because I make sure that they do it before they leave my office. That's very important. And it can also work in radiotherapy patients, although, as I said, the erosion rate is a little bit higher in radiotherapy. So I see the radiotherapy patients a bit more often for follow-up than the non-radiotherapy patients. But overall, the satisfaction is very good. Like, people have written papers, even with radiotherapy, when patients have to undergo revision surgery, at the end of the day, they still are happy, and they would still recommend it to a friend. So it is the gold standard treatment.
Okay, Vincent, we have some questions coming through regarding the AUS. Quite a few. We asked the questions and we're getting them. What is the risk of erosion or infection requiring removal with an artificial urinary sphincter?
The risk of erosion, if you only had radical prostatectomy but not radiotherapy, and you go to, and your surgeon, do reasonable experience and have done quite a few of these before, then the erosion should be less than 5%, say in about 5 years. So at the end of 5 years, your risk of erosion should be less than 5%. That is the ballpark figure. But if you have had radiotherapy, then it can go up to 15 to 20% at 5 years. Yeah, and all it's all got to do with the the severity of the radiation effects on the tissue, plus the surgeon, the cuff size that he or she choose for you, and that comes with experience. Because obviously, if you choose a smaller cuff, smaller diameter, and squeeze it a bit harder, of course you get more likely to be dry. But then if you have had radiotherapy and there's already less oxygen going to that tissue because of the radiotherapy, and then you put a tight cuff, it's a bit like strangling. There's no blood going in, and within a few months it might erode. So I treat everybody who have had radiation with the utmost respect to the tissues, because that if you don't look at it carefully and treat it meticulously, it'll bite you back. Yeah, and when it bite you back, then the patient suffers. So we want to minimize that happening.
Vincent, another question: can you have an AUS with a penile implant?
Yes, of course. You can have both in. You can either have one or the other first. You can have a penile prosthesis first, and later on put the AUS. But in my experience, it's always the other way around, is because most men do not want to have any sexual life unless they are pretty much dry. So almost everyone wants their urinary continence back first. So usually it's the AUS or the male sling first. And once that's sorted, then the questions always pop up at the next follow-up is, now, doctor, what can you do about my erections? So it's almost always that sequence.
Are slings also contraindicated in radiotherapy following robotic surgery? PSA has gone up, as well as the initial radiotherapy as first treatment.
Yes. Oh, you mean the radiotherapy is adjuvant radiotherapy from PSA recurrence? Yeah, it's any radiotherapy. If you have had radiotherapy in your pelvis, then the sling is well, I mean, I can't, to be fair, I can't say it is an absolute contraindication, because I know there are colleagues out there who do use slings in people who have radiotherapy, and some of them works, you know. But when we looked at our data, and if you do follow these patients up for 4 years, then more than half of them don't work anymore. Yeah. So so to us, based on our own data, you know, and also multiple other authors from around the world, is that if you have had radiotherapy, you probably should avoid a sling, you know. But if the patient is insistent on a sling, then you have to explain to the patient, yep, I'm happy to do it for you, but you may fail earlier. Yeah.
I think we have a bit of misunderstanding here, but perhaps you can still answer this. What is better than a TRP for stricture clearance? Stricture
clearance. Yeah, I can give a 1-hour lecture on this topic, but actually, to put it simply, it depends on the how tight the stricture is, whether it is related to radiotherapy, and also the length of the stricture. So if you have what I call a simple in quotation marks, simple stricture, a short stricture, not radiotherapy related, and not too narrow, then usually just a dilatation. Usually, you know, your urologist would explain to you is a dilatation with some sounds, and stretch it open. They may or may not leave a catheter in for a few days, and you have a probably 60 to 70% chance that that mild stricture will be fixed forever. But the longer the stricture, the narrower the stricture, and the denser, you know, the more rigid the scar, then the failure rates go up with simple dilatation. Then you've got to have other things like put a telescope in and actually cut out the scar. You have to actually physically cut out the scar with it's like planing wood. Pieces of it come out to enlarge the channel. Sometimes we inject anti-inflammatory medication like steroid injection, anti-inflammatory, to reduce the recurrence of the scar. Sometimes we have to even do major surgery, you know, plastic urethroplasty, plastic surgical repairs to treat the most difficult scars. Yeah. So it doesn't always it's not always transurethral. Sometimes we have to do open or robotic surgery to treat one of the worst scars. I've done about 2 now. I don't know whether Carly, can't remember whether you were with me when at Macquarie, but we have to do a robotic bladder neck reconstruction in one of those patients that are very, very difficult. They fail everything else. Yeah. So,
Vincent, sorry, we've got a few questions coming through, and we also wanted to speak to our panelists. So at some point we'll stop and switch over to them. This person had a prostatectomy 20 years ago, and the incontinence has only started now 3 years, so 17 years later. Is it too late for intervention?
No, but nothing is ever too late, because we are functional urologists. We are here to help. But anyway, so to be serious about this, if it's 20 years ago, the incontinence may not be related to the prostatectomy at all. It could be bladder related. This patient may have overactive bladder with urge incontinence, or it may be stress incontinence, but when he was 20 years younger, his pelvic floor and sphincter muscles were reasonably good. But as I mentioned to you much earlier, from aging, the sphincter muscles and pelvic floor will reduce in bulk, and at a certain time, at a certain critical point, the sphincter muscle might fail. So it sounds like maybe this is the case, is that 20 years later, the sphincter muscles now have dropped below par. So pelvic floor muscle training would be important. So it will be a good idea for this patient to see a urologist, sort out whether it's overactive bladder first, maybe try some medications. But if it's not overactive bladder or the medications don't work, then he may need to have a urodynamic study. Urodynamic study in older men are very useful, because the older you are, the less your symptoms correlate with the true physiology. When you have a very young person with urgency and urge incontinence, it's almost pounds to peanuts overactive bladder, and you give them pills to take. But if an 80-year-old man presents with overactive bladder and urgency, there's more than 50% chance it is not overactive bladder. And we have proven that also in our research. We looked at almost 300 urodynamic studies, and in people who are over the age of 80, and more than half of the patients who present with urgency do not have overactive bladder on their urodynamics. So if you give this patient Ditropan or Vesicare or Bentmega on spec because you think this man has overactive bladder, you may be barking up the wrong tree more than 50% of the time. So I am very proponent of doing urodynamic. The older you are, as long as you are cognitively sound, cognitively good and ambulant, you should have a urodynamic study before trying this and trying that, because as I just mentioned, you get it wrong 50% of the time, and if you give the patient the wrong pill and then they feel dizzy and they had a fall and break their hip, you're not doing that patient much good service.
So yeah. Do all patients get urodynamics before a sling or an AUS?
If you're a functional urologist, yes, because all my colleagues around the world, if they're going to do an irreversible, practically irreversible procedure, which is surgery, I think it warrants maximal information.
And can it dictate whether you do a sling or an AUS? Does the UDS help make that decision?
Yeah, the urodynamics may find out for you whether you have reduced bladder compliance, the elasticity of your bladder. It may ascertain whether you have the bladder overactivity. It may also discover a stricture for you. If you can't put a catheter in during the urodynamics, then you've got a stricture. So that sometimes will be encountered. Then you've actually got a stricture, which then may cause overactive bladder and leak. So all of these are interrelated. It could be. So in my books, in my opinion, urodynamics should be done before sling or artificial sphincter surgery, and many of my colleagues, both in Australia and internationally, will say the same thing.
Are there different brands of sphincters, and do they all have reservoirs?
Well, the most studied in the world is this one, the AMS 800. There are a couple of newer ones in the market, but they haven't been used very often around the world. There's a big toe device, which also has a cuff and a balloon, and another balloon that branches off this balloon to reduce the risk of erosion. But it's not very popular worldwide. I think a lot of surgeons do trust the AMS 800 the most because they, it's been around for a long time and everybody knows how it works. And if you have to go overseas or travel somewhere else and you have a problem, and you just go to the nearest hospital, if you're in London or New York or South Africa or Japan, everybody knows how to sort it out. But if you have one of these newer ones and then you have to travel and then something happens, then maybe nobody have ever seen it before in a lot of places. So I think there are a lot of factors that are involved, and also these newer devices haven't been subjected to long-term follow-up studies and randomized control trial and so on, like some of these other ones. So I think most of us still use this one.
Thank you. Someone here is a cyclist and likes to cycle obviously for many hours. Is it okay to get an artificial urinary sphincter and a sling?
Good question. I do have a few patients who are avid cyclists. You just have to get a split seat, and I'm sure that particular person knows what I'm talking about. So you can still have a bulbar cuff AUS or even a sling. But if you have an AUS, you should get a split seat or a seat with a groove in the middle. Then you can still cycle.
Vincent, you mentioned a double cuff AUS before. What is that?
Oh, a double cuff is when you have in tandem. So you can see in this picture here, you've got just a single cuff, but you can actually, the company does provide a connection where it branches into another cuff. So there are actually two cuffs in tandem, and that is supposed to be for people who leaks a lot. So let's say if you have one cuff like this, and then the patient says, "Oh, look, doctor, I'm generally better, but I've gone from 8 pads to 2 pads. Can I get any better?" The answer is yes. You can either put a tandem cuff next to that cuff, or you can reduce the size of the cuff. But those situations doesn't tend to come very often because I tend to measure it correctly and get it right the first time. But if that happens, then you can have the patient choose either a tandem cuff or downsize the single and use a single cuff. Yeah, I personally do not favor double cuff because it's extra prosthetic material and it increases the risk of infection and erosion.
Vincent, thank you so much. We're not quite done yet. I thought we'd give you a break and your voice a chance to relax.
No, I don't. I mean, unless you want to have a break, I'm actually fine. I've got my water here, so I can.
We're so incredibly grateful, honestly. We can just hear how passionate you are about this topic, and the years of experience just shine through, and clearly you're well researched on it as well. And this is why international people look for your expertise. So we're grateful to have you here today. I want to now switch across to our panel. We've got 2 of our support group members that want to share their story with you all. Okay. There's some few questions that are still remaining.
We still got plenty of time, half an hour.
So we will come back and answer those questions for those of you who have asked. Please remember, everyone, we're going to be doing a series of webinars going forward, touching on topics like sexual dysfunction and wellness and health and exercise. So we're going to be exploring all kinds of concepts with keynote speakers like Vincent, talking to you and giving you an opportunity to ask all the questions you wanted to ask. So please stay tuned. That will be through the course of next year. We'll also be sending you out a feedback survey at the end of this, so perhaps you could tell us what you'd like to hear more about in future webinars, and also where we did well and where we could improve. So thank you. And we do run a monthly support group, so if anyone would like to join the support group, you're very welcome. And we do acknowledge all our other support group leaders that have joined us today. Thank you so much for joining this session. So we're going to switch now to our panelists. And Nicholas, if you could put up the panelist slide, I can just show you who they are, and I'll introduce them to you. So we have, so Gary will chair the session with me. We have Ray, we have Jeffrey and we have Colin with us, and they're going to tell us what their journey was briefly, and then we can have a discussion after that. So let's start with Jeffrey. Jeffrey's up on screen. Thank you, Jeffrey.
Well, thank you. Vincent, I thought your presentation was fantastic. I learned a lot, and I'm sure everyone else did as well. About 2 years ago, I was diagnosed with prostate cancer, and in December 2019, I had a radical prostatectomy, which unfortunately left me with urinary incontinence. At the time, I was told that it'd probably clear up in 3 months and just keep on doing the pelvic floor exercises. But unfortunately, nothing changed. I was then put onto a medication called Bemega, but Bemega didn't make any difference to my situation. And by that stage, I was finding life very difficult, both on a physical level and also on a psychological level. A lot of it was the things that Vincent touched on, things like having to change pads all the time and the general inconvenience. And so also psychologically, the whole scenario was very sort of depressing and got me down. Mm-hmm. I was then referred to see a functional urologist who did the urodynamics test, which Vincent was talking about. And as a result of the urodynamics test, it was recommended that I have a pelvic sling. I had the pelvic sling operation in August last year. And from a patient's point of view, it's a very easy, very sort of straightforward procedure. It wasn't nearly as daunting as having the radical prostatectomy, and also the recovery period was a lot quicker as well. Basically, you just go into hospital one day, have a 45-minute procedure, you come out of theatre with a catheter in, following day they take the catheter out, and after 3 successful urinations, you go home. And for most people, it works straight away. So as a result, my life improved dramatically, almost overnight. And I'm now looking forward to a fairly normal life. I do have a little bit of incontinence still, only about 5 milligrams a day, which is quite manageable. And as Vincent said, you don't really become 100% dry in any case. And I just wear one sheath, and I just have to change it about once a day, and it's very convenient. So I'm now looking forward to having a very continent and cancer-free life in front of me. So thank you very much for listening to my story.
Thanks for sharing, Jeffrey, very much. We very much appreciate it. Vincent, do you want to add to anything that Jeffrey said?
Yes. Oh, that's, it's very good. It sounds like you had you came through the procedure very well, no issues. Did your flow slow down a bit after the sling, or pretty good, the flow?
Still pretty good.
Very good. Good. Yeah, excellent. So no, I think this is a typical, story of how a patient goes through post-prostatectomy incontinence. Is the investigation, the urodynamics, and then the counseling about the options, and then the surgery itself, which, as Jeffrey says, is reasonably smooth. The surgery takes about an hour or so. Some practitioners leave the catheter in for a few more days, depending on how the surgery goes, but it sounds like your surgery probably was very smooth sailing. So you only have the catheter in for overnight, and then they took it out the next day. And also sometimes people leave the catheter in for a couple of days longer, depending on the difficulty of the surgery. But yeah, I'm very happy. Yeah, and as Jeffrey mentioned, it is immediate, the result, because it is a compressive sling. So what you see is what you get. Yeah. So once the catheter comes out, maybe within the first day or two, you will pretty much get what you end up with. Yeah. And hopefully, Jeffrey, you are continue to do some pelvic floor exercises.
Yes, we continue with those.
Yeah. You shall not sit on your laurels. So keep doing the exercises, so that when you get older, you have good bulk there. Yeah. Once a sling is put in, it becomes because your scar tissue grows on the scaffolding of the sling, so it becomes like a tendon. So it's like you have like got a new Achilles tendon of your urethra. So that's why you're pretty good now. So the sling doesn't change, but your sphincter muscle may continue to age with time. So that's why it's important to stimulate those muscles by contracting them, and the bulk should stay the same. And I tell also my patients not to put weight on, although in the last 18 months it has been a bit difficult for some of us. But after Freedom Day, hopefully you can go back and do your exercises and don't put, because when you get overweight, it also increases stress incontinence.
Jeffrey, there's a question here from James asking you, are you still wearing a pad at night?
No, I'm not. I found even before I had the sling that I wasn't losing very much overnight anyway. It's mainly during the day when I tend to leak. So at nighttime, I don't wear a pad at all, so it's not necessary.
Great.
Can I make a quick comment here for
Yes.
those of you in the audience? When you have almost pure activity-related incontinence from prostatectomy or radiotherapy, most people do not leak at night when they sleep, or they only have a few drops. So if you do leak during your sleep as well as during the day, you either have reasonably bad stress incontinence, or you may have other underlying bladder problem. So just just for your information. Yeah.
Thank you very much. I want to ask Colin to share his story with us now. Thank you, Colin.
Hi, yes. So I had I was diagnosed with prostate cancer in 2014, the end of 2014. I had a robotic-assisted prostatectomy at that time. Incontinence started as soon as the catheter came out, and it was quite distressing and debilitating. Had quite a number of accidents publicly, which actually was very embarrassing at that time. I did have physiotherapy, and I did my exercises. I actually had the physiotherapist talk to a personal trainer, so I was continuing on trying to get these exercises done. It was very, I think Jeffrey mentioned it is depressing, and it does affect your mood. And I ended up seeing a psychologist because I was really in a bad way. The impact on my life, well, it was difficult with traveling, because whenever you go anywhere, I live out in the Blue Mountains, and I always had to think out where the toilet was wherever I went to make sure that I got there in time. I carried a little rucksack which had pads, wipes, underwear, etc. with me, just to change if I had an accident. Pads were okay, but sometimes they failed, and that was the embarrassing part of that. And it happened at work as well, as I was working at the time as well, so it happened at work. And one of the things I found with, which was interesting, for where you have a pad and you go into a public toilet, unlike the female toilets where there's actually the bin there to get rid of the pad, there was no bins there. So basically then you had to go out into the public area and throw the pad away. It was very embarrassing. So I was very stubborn and very, I didn't want something inside me. So it took me a couple of years. In July 2016, I had the ATOMS device put in, and that was amazing. I had to have about 3 adjustments over this time. And what it did do, well, basically I was able to do weightlifting competitions, including Olympic lifts, which I don't know if you're aware, the snatch and the clean and jerk. That takes a lot of pressure, so I was able to do that. I climbed a mountain in Nepal. I was able to have my life back, basically. That was it was a positive experience. So,
and you've done a PhD, Colin.
And I did my PhD as well, yes. So, and it's actually on cancer and the LGBTQIA community. So yes, yeah.
Yeah,
That's fantastic. Yeah.
Vincent, do you want to say something?
I mean, no. I mean, it's really good. It's fantastic to hear that. I mean, that's the whole point of doing these operations, is to have you be able to climb a mountain, and do the activities that you want to. I'll just quickly share something. A number of years ago, I had a patient who is 83 years old, right? So he had a radical prostate in the mid-90s. And for 20 years or so, he was fine. But then, 20 odd years later, it started to leak. But he was already 83, and he starts to not having very good hands, and he was leaking quite a lot. So I said, look, because of this, you probably won't be able to have an artificial valve. And then he goes, no, I don't want to have that. Can you just put a sling in? Because I just want to do ballroom dancing with my wife. If you can reduce my leakage, I'll be very happy. So even with 600-gram pad weight per day, I still gave him a male sling, and he went really well. And he went down from like 6 or 7 big pads to one or two medium pads, and he was able to get back to dancing. So that's as I mentioned before, the 400 gram per 24 hours as a criteria. It's flexible, yeah. So you can still put a sling in for bigger pad weights. Depends on what the patient expectation is. Yeah.
Thank you. Thanks, Vincent, for that. Just everyone, we posted in the chat the link to our feedback survey, so please do click on that before the session ends, or even afterwards, just to give us the feedback. It's only 5 questions. It will take you literally 2 minutes to complete, and that feedback will be very valuable, as it will dictate how our sessions will go, will be run going forward, or what topics we'll present to you. So thanks, Colin, for sharing your story as well.
Can I just add one more thing? There was a question earlier on about cycling, I think, earlier on.
That's correct.
One of the things with the Atoms device was that I was not to do cycling or horse riding, which is a shame. But I actually do use a stationary cycle, but I actually have that special seat. So I actually have it's actually got a hole in the middle of it, sort of thing. So it's actually, I can do that. So it doesn't stop you.
But what about one of those gel foam pads? If you would like horse riding, have you asked your urologist if you sit on one of those really soft, like those Tempest mattress, the really soft ones? If you put one of those on the saddle, maybe it's all right,
Right, yeah.
But you could ask your surgeon.
Yeah, thank you.
So, Vincent, there were some other questions that came back from earlier. Let me ask you before we end the session. Someone here has got urgency. So when they have to go, they really need to go. Will an AUS work if urgency control is an issue for them?
No, I think if your incontinence is predominantly urgency incontinence, that will need to be sorted out first, because you need to have a urodynamic study to see whether it's due to overactive bladder. Because if you put a artificial sphincter into an overactive bladder, it may potentially make it worse. So that has to be sorted out before. Yeah, the sphincter is only for activity-related incontinence. The sling as well. Yeah.
Okay. Another question was relating to, what's your opinion regarding surgery versus radiation for prostate cancer? Looking at everything you now know and the complications.
You're asking me?
Yes.
I think for clinically localized prostate cancer in a young, fit, healthy male, both options are of course suitable, but I would prefer surgery because it is clean, in quotation marks. Being a functional urologist and a reconstructive urologist, I do get a bit of a biased view because I get referred from all over the state of radiotherapy complications, such as strictures. They are really, some of them can be quite severe strictures. We get referred patients with radiation cystitis. My colorectal specialist colleagues get radiation proctitis to manage. Although they are rare, but they are there, and if you happen to be the 1% out of the 100 that gets it, for you it is 100%. So if there's an option, I think if that's discussed at the MDT meeting, now, as you know, now all hospitals have these multi-team meetings. Most of these cases will be recommended surgery. Even a radiation oncologist would say have surgery. But that's my experience. Yeah.
Sure, and your opinion, and thank you for that. And we have someone that leaks a liter a day. Would you skip the sling and just go straight to a sphincter?
Yeah, I think if you leak a liter a day and you want to get close to being reasonably continent, yes, an artificial sphincter if it's a liter a day. Yeah, but got to do urodynamics. Make sure that some of it is not overactive bladder, because I've had patients who were referred to me because they leak 600 grams a day, and they said, "Oh, Dr. X referred me to you for artificial sphincter." And then I did a urodynamics, and the patient had a lot of overactivity, reduced compliance, and I treat failed Vesicare, Badmiga, Ditropan. So I Botox his bladder, give Botox to his bladder to treat the overactive bladder, and his pet weight came down to 200 grams. So from 600 to 200. So I said, now you can have a look at the sling. So that's another reason why it's important to do urodynamics, because you can see in this patient, it completely changed management, because the original urologist thought he needed an AUS. But after I did a urodynamics and worked him up completely, we put a sling in, and it worked. And he's now 8 years later, he's still reasonably good, Yeah, I think urodynamics is very important.
Speaking about urgency, there was a question that came in. I'm assuming it's related to urgency. When do you use Botox in the bladder, and is there any contraindications to using it?
Botox is the procedure itself is very, very simple. It can be done even under local anesthetic, with a flexible cystoscope or just a very, very light sedation. It can be done in 10-15 minutes. It always wears off. So if it works, you've got to go back for repeat injections. Usually within 9 to 12 months, you have to have repeat injections. Contraindications, you have to make sure that you haven't got underactive bladder. So if your bladder contraction strength has to be reasonably good, and you should be able to empty your bladder well, because if you have impairment in bladder contraction, it may be a relative contraindication with Botox. Yeah, because of retention. But the thing is, even if you get retention, it's not the end of the world. It's temporary. It's not permanent retention. So you just got to be inconvenienced by a catheter for a while. But once the Botox wears off, then you can void again. Yeah.
Gary, sorry, we haven't spoken much to you. You didn't have troubles you had a radical prostatectomy, didn't you? You didn't have any issues with urination?
No, in actual fact, I was one of the lucky ones, and I've had a robotic surgery going back 12 years ago now. And after surgery, and once the catheter was removed, I basically threw the pads away after 3 weeks, and I've been able. I haven't had any problems since. The only time I do probably have a little bit of a squirt would be if I'm tired or I've had too many drinks, so it's, I've been very, very fortunate. And just listening to you, Vincent, has been just absolutely extraordinary, because having been involved with our support group for 12 years, meeting Colin, meeting Jeffrey, and a number of other of our members, the incontinence issue has just been one that's led men to depression, and then, like both Jeffrey and Colin, once they've tackled the problem, got the right advice, got the right treatment, their lives are completely turned around. And you're so right in what you said at the very beginning of your talk, that you don't have to live with this. it is about trying to find the right functional urologist to be able to assist you, but also to get the right information. And what you've given us today is just been absolutely first class, and just delighted to have you as our first of our speaker for our series.
Yeah. Thank you for your kind words. I mean, I think, as I mentioned also at the beginning, you know, when you go and see the doctor in the first place with just a raised PSA, you know, you're not suffering at all, and all of a sudden, you know, before you blink of times, and then you have to wear pads, you know. So that is a complete abrupt change for the worse, and you know, it's important to get it sorted.
And I think the other thing is too is that men being men, we tend to suffer in silence. And unlike female counterparts, we don't speak up as much. We tend to live with the problem, and that leads to clinical depression, to so many other issues. And people like yourself and are just extraordinary in the journey for prostate cancer for men. Absolutely.
Yeah, it's like Vincent is actually shining a light, isn't it? He's the hope, the light that can change people's lives. I have another question. Sorry, Vincent, another question. Where can one go for more information on moderate stricture treatment after radiation, currently self-catheterizing with difficulty?
Yeah, I think if you do have a stricture issue that's recurrent or recalcitrant, it is probably time for you to seek advice from a functional reconstructive urologist. It's hard to find information out there for strictures because it is a very technical sort of problem, you know. So if I mean your urologist might have recommended you, for example, like self-dilation, you know, maybe put a catheter in once every other day or something to try to keep the stricture open. But if that's not working for you, or if you don't find that it's a very acceptable management option, then you should seek help from a functional or reconstructive urologist, because you may be able to help with either, you know, stents or other endoscopic treatments that will increase the durability of the success, you know. So that's what I advise, is to seek further help from a urologist.
I've got one quick question, and I know we've got to wrap up because this has just gone brilliantly. I'm a doctor of politics, so not a doctor of medicine. Okay, so that's the first thing. Second thing is, when you say a urologist and then you've got a functional urologist, how many of your type of urologist is there around the country? And we've got people in New Zealand and what have you. Yeah. And just a little sub question to that. If I'm going to a urologist who's not a functional urologist, would he or she refer you to a functional urologist, if you understand where I'm coming from? Yeah.
So when we graduate in urology, we have pretty good solid background knowledge of every condition that we have to treat. So if the patient go and see any urologist, they should be able to manage fairly straightforward, non-complicated strictures.
Right.
Okay, but if it gets complicated, then that urologist will refer, and most of them will, and some of them, you know, they're a bit difficult to refer, you know, because they like to treat their own patients, but most of them, 9.9 out of 10, will refer to a functional or reconstructive urologist. Yeah. Right. And also the patient will know as well. I mean, if the patient sense that urologist is not giving me what I needed, that patient will also initiate and go back to the GP and ask for a second opinion. So that this is sometimes what when I see some patients, some of them are directly referring from other urologists, but some of them are from the GP, you know.
Yeah, and the reason why I asked that question is at our recent support group meeting, there was a gentleman who was in Canberra, and yes, there's not a functional urologist like you in Canberra. So you know, it's you've got to seek them out, and that's
yeah. So the Urological Society of Australia and New Zealand website has a helpline. So if you're unsure of where these different subspecialty urologists are, just ring up the Urological Society of ANZ, and the receptionist will be able to direct you.
Right, brilliant. Over to you, Kelly.
Yeah, there was one last question. Can any of your procedures to correct incontinence affect penile size? I know the original radical prostatectomy surely can reduce the size of the penis a bit, but can any of these procedures do that?
It doesn't actually reduce penis size, but what it does is sometimes if you put a sling in, it may, because it compresses the bulbar urethra. So some patients may notice some shortening of the penis, but it is not a recognized complication. And when I ask the patient, have you ever pay attention to what it was like before the sling? And some of them already said after their radical prostatectomy, it's shorter anyway. So I think I don't think the procedures itself actually cause any penile shortening. I think most of those penile shortening phenomena are already established after the radical prostatectomy, because you have to lose, because you take the prostate out and you join up, so you lose about 2 to 3, sometimes 4 centimeter when you pull the urethra up to join to the bladder. There's some shortening there.
Yes. I think we've hit 3 o'clock, and it is a Saturday afternoon after all, and I know you've got a life to get back to as well. So we're just, as I said, I can't keep saying enough, so grateful to have you join us this afternoon and hear about all your years of experience and wisdom. And thank you.
Can I just say one last thing while we've got everyone here? Is because I was I was the chair of the New South Wales Continence Foundation of Australia. We championed very hard with the government to put bins for pads in public toilets. So you may already start to see some out there. And it is a major collaborative by the Continence Foundation of Australia, and it's through the hard work of the Continence Foundation that this is now come to fruition. So there's now government funding to install these bins in men's toilets all over the country. So you may start seeing them very soon, and I think it's a very, very big project that is successful.
Well,
so
worthwhile.
It's very good.
Yeah, that is great, Colin. I hope you approve of that. Yeah, Vincent, once again, thank you so much. And thanks for everyone for joining us, logging in. Please, you can contact us at any time. We've left our email address there, and we hope to see you again at our webinars coming up in the near future. And thanks again to our participants, Jeffrey and Colin, to Gary, to Nicholas, who's helped us with the IT in the background. And yeah, have a lovely day and stay safe.
Just one quick thing before we do go. It's been 2 years that we've all lived through COVID. I sit in Canberra a bit. We're coming to hopefully that moment of freedom. I know for me, even though I've been able to move around a little bit, it's been a very testing time for a lot of people, and a very testing time for many of us that have been cancer sufferers and cancer survivors, and those just trying to get through life generally with issues like we've discussed today. But above all, be safe, be well. There is light at the end of the tunnel, and seek help if you need it in any form, and that's so important. Thank you, Vincent.
Thank you, and thank you, Carly, for sharing. It was
Brilliant.
very good, and thank you, everybody. Nice to meet you all, and I'll be very happy to talk again in the future if you think the time is right for another refresher course.
Thank you so much.
Thank you. We've got thank yous coming in from the participants, Vincent. In the chat.
Excellent.
Thanks.
Very nice.
Yeah.
We'll catch you soon.
Cheers.
Bye-bye.
Take care. Bye.